common things are common, and you get to recognise things that are uncommon and need different attention. So seeing lots of children with viral infections whilst annoying at 3 o'clock in the morning makes you a better doctor.
It's not a case of not wanting to prescribe antibiotics. It's about wanting to do the best thing for the child in front of us.
Part of what we do in medicine is explain and reassure, and that is actually harder than giving out pills and giving out medicine. And that is the art of being a paediatrician. Hello everyone, and welcome to the Peds Round, your regular podcast from the Royal College of Paediatrics and Child Health. My name is Emma Lim. I'm a consultant paediatrician at the Great North Children's Hospital in Newcastle upon Tyne. Together with our guests, we'll dive into some of the hottest issues affecting our specialty. We'll try and bring you insights from paediatric experts and round up some of the key learning points for your practice along the way. So let's get started with our Peds Round. It's the beginning of the new year, and I thought it would be really interesting to talk about one of my favourite bacteria, group A Streptococcus. And so to help me, because we always need help from experts, I have Liz Whittaker here to talk to us.
So I'm Liz Whittaker. I'm a paediatric infectious diseases consultant in London and an academic at Imperial College. And I am the convener of the British Paediatric Allergy, Infection and Immunity Group, which is why I end up talking at lots of these things.
Liz is on one of my phone a friend people. So when I'm horribly stuck, she's one of the people who's A, very nice, and B, knows all the answers. Always the best.
I actually know all the people who know the answers, Emma. I think that's the key. Yeah.
I also have my sidekick to keep me on the straight and narrow, Christo.
Morning. My name's Christo. I'm a research fellow in Newcastle working with Emma and currently doing a PhD in paediatric immunology.
And so let's dive straight in. One of the things that I always think about with bacteria, people seem to think bacteria are bad, but actually bacteria live on our skin and in our throat all the time and don't really cause us many problems. So what I'm really talking about is commensals. Liz, can you talk a bit about group A Streptococcus, what it is, and carriage rates?
So group A Streptococcus is a member of the streptococcal family, and we learned about this in med school, and I remember spending a lot of time on streptococcal and staphylococcal bacteria in microbiology. And I've got to be honest, at the time it didn't make any sense. But subsequently, both as a junior doctor and then as a consultant, I've realised how important both of these wonderful pathogens are. So they're not just pathogens. We are covered in bacteria. It's really important for our immune tolerance and our development of our T cell responses and our ability to recognize foreign from not, and in particular our pathogen recognition receptors. And so we are covered from head to toe in not just by bacteria, but also viruses as well. We have a microbiome, which is both bacteria and viruses. And carriage rates are surprisingly high. So we have this problem, and this is one of the reasons why diagnostics become slightly challenging, particularly in this context, is that many people carry streptococcal bacteria at the back of their throat without causing them any harm at all. And so it's really difficult to say just because you found something on a throat swab or in a rapid test that it's causing a problem. You have to take it in the context of how the child is clinically presenting as well.
Thank you. I mean, I think that says it all so clearly that lots of people have strep, but it only causes disease in some people. And even in those people, it might cause minor disease, and very, very few get seriously ill.
Liz, is this why rapid antigen testing isn't recommended by NICE?
This is almost exactly why rapid antigen testing hasn't been adopted in our setting. And it's interesting, and I think lots of people say, oh, but it's used all across the United States and Canada and Germany. They have a very different healthcare system structure as well, though. And they are used in the context of clinical scoring systems and not just as a tool by themselves. But we know that if you treated every child who had a positive rapid antigen test with antibiotics, you'd probably be over-treating by between 90 and 95% of those children. And that's a lot of antibiotic that's not needed. So we should try and avoid that.
Absolutely. That is my favorite words, avoid antibiotics. So let's say we have people where bacteria just sit on their throat and they don't do anything, but we see a lot of children with sore throats. That is a really common presentation. So how do we pick apart those with just viral illnesses from those with strep throat?
That's such a good question, Emma. And there are a number of scoring systems that have been developed and really validated in adults, if we're honest, with some data in children. So the Centaur scoring system or the fever pain scoring system are the ones that we use, and usually in children over the age of 3. But as a general rule, if they're full of snot and they're coughing and spluttering, if they've got a classic virally looking rash, and they've got a sore throat with that, that's probably going to be a viral infection. And this is where, and as you get more senior, it's easier. You learn to trust what you know. And this is why we make you go to A&E and see lots of patients, because common things are common and you get to recognize things that are uncommon and need different attention. So seeing lots of children with viral infections whilst annoying at 3 o'clock in the morning makes you a better doctor.
Those scoring systems that you've mentioned, Liz, are really helpful for trying to pick apart viral versus bacterial tonsillitis and sore throat. But do you think every bacterial or likely bacterial tonsillitis requires antibiotics?
So that is such a good question. And no, I don't think they do. The vast majority of tonsillitis is self-limiting. There is lovely evidence showing that antibiotics might reduce your symptoms by maybe a day, but not much more than that. And actually, when we go back to that immune question before, having repeated episodes does help you to develop protective immunity against some of these infections, provided they stay mild and allow your immune system to develop the way that it should. Because although we don't have a vaccine against group A strep, and so protective immunity is a little bit elusive, we don't continue seeing tonsillitis and group A strep infections throughout childhood. At some point, people develop the right kind of immunity that stops them from getting ongoing tonsillitis.
I think that's so important. I'm always saying to parents when they bring their snotty children in, there is a plus side to this. This is going to help your child develop a good immune system. And I think that's really vital. Going back to talking about antibiotics, number one, we just shouldn't prescribe. Number two, even if we do prescribe them, as you said, it might only shorten the course of the illness, not even do it much else. But I think it's really important to think how we give antibiotics. We're a big fan of pill swallowing. And I'm very keen that people don't give 10 days of oral penicillin. Have you tried giving penicillin 4 times a day to a struggling toddler? And there are a lot of other better options.
Absolutely. I couldn't agree more. I think there's a great opportunity here whilst the stage is looking at antibiotics to do a bit of education for parents in particular, but also those who work in primary care and in frontline settings who prescribe the bulk of this kind of antibiotics, to say that we should be encouraging children from the age of 5, maybe younger if they're very honest, to try and swallow pills. And I have to confess, my children have been very lucky and not had many illnesses in their life. And I taught my 9-year-old to swallow Tic Tacs over Christmas because I was so embarrassed that it had never come up before. But I realized that I just hadn't been on my agenda of things that we need to do. And we need to make that part of parenting, is that actually over time you teach them to ride a bike. You need to teach them to swallow a tablet, part of growing up.
And on the topic of antibiotics, what are the kind of good alternatives to penicillin V?
One of the things that was extraordinary in December of this year was the big media coverage of antibiotic shortages, which I think was very alarming for both parents and clinicians. And a rapid protocol was developed to allow pharmacists to give good alternatives. So actually, I was involved in some of those meetings. We've thought about this a lot. So first line recommendations are amoxicillin, very palatable for children, and penicillin. After that, the other options are things like macrolides, although we have to remember there's between 8 and 11% resistance to streptococcal infections from macrolides, and that would be azithromycin and clarithromycin. Augmentin, but again, it's quite broad spectrum and is more associated with GI side effects, so that wouldn't be top of our list. We have cefalexin, a very underused antibiotic, but actually very effective and quite palatable. And then we have things like Septrin, which was what we got when I was a child, but kind of has gone out of vogue a little bit, but is a really good alternative as well. So I think there are lots of options. What's currently, until things change, you can just write penicillin on the prescription and your amazing pharmacist will choose an option if they do not have what you want available for them, including probably amoxil quite high up there.
And this is one of my huge bugbears, is that people don't understand when they get antibiotics have side effects. And you mentioned GI, gastrointestinal side effects. So when you have an antibiotic, it doesn't just kill the bacteria in your throat, it kills all the healthy bacteria in your gut, and you get a bit of diarrhea. It does not mean that you are allergic to that antibiotic. But all medicines have side effects, and that's why they should only be prescribed with caution.
I think this is really important to communicate across to parents and to families when we're counselling them and safety netting, that it's not a case of not wanting to prescribe antibiotics. It's about wanting to do the best thing for the child in front of us. And if the potential side effects are going to cause more distress and add, say, diarrhea on top of a child who's snotty and miserable, then foregoing antibiotics might be the better choice for that child. It's just sometimes difficult to be able to communicate that when you've got parents who are stressed and tired and you're busy in a GP surgery or in A&E.
And they just want their child to get better, Christo. So, I think I'm slightly worried that with all these children with viral infections who are given antibiotics, that they will go through the normal history of a viral infection and develop a maculopapular rash, which is self-limiting, but that will be labelled as an allergy. And so what I also think that as clinicians, both in primary care, but also in A&E, that we can say to parents that doesn't look like an allergy, so they don't get labelled as having an allergy for the future. I also think that the important thing about not giving antibiotics is to give parents the decision-making ability about when to come back. Because although the vast majority of these children will get better and not need more medical attention, a teeny tiny subset might get severely unwell. And the safety netting advice and that ability to give that decision-making to parents is so important as part of our job.
Thank you, Liz and Christo. I think this is such an important thing. I think part of what we do in medicine is explain and reassure. And that is actually harder than giving out pills and giving out medicine. And that is the art of being a paediatrician. Obviously, we've talked about strep throat, but group A strep can cause more significant illnesses. And one of those is scarlet fever, which actually used to be really common.
But it was. Scarlet fever is, and also in Victorian times, and you read about it in literature, don't you? It's so fascinating. And I Little Women is my book, my go-to book for scarlet fever and rheumatic fever education. So scarlet fever is something that we probably need to think about a bit more seriously. Interestingly, probably most people get better from scarlet fever without treatment, without any sequelae, but it is slightly more likely to be associated with complications. So at the moment, the recommendation is that we would treat it. However, fever and a rash is probably the second most common thing that you're going to see in primary care or A&E. So understanding how to recognize scarlet fever is quite important. So children with scarlet fever develop a flu-like feeling with headaches, high fevers, and sore throat. And then the following day or the day after that will develop a very red rash. And very interestingly and very importantly, it doesn't always look red in all skin types, but the fascinating thing is you can feel it. And people say sandpaper, it's rough skin and it's kind of all over the body. And it starts on the trunk and then it can also spread upwards. And that's different to other rashes that might look similar, like measles. And we're a bit worried about measles vaccination uptake for the preschoolers. So you do need to know what measles look like. Starts on the face and spreads down. So just remembering to take a history, not only of where the rash started and what it looked like, but how it progressed over several days will help you to make that diagnosis.
That's so funny. Little Women, I totally think you're Joe. It's like, can't
Yeah.
hold.
Yeah.
Yeah, I think that's a really good point about rashes. We see a lot of rashes. The first thing I always think about is take a history. Is the child actually ill with the rash? But so often it's really minor and they're not ill, and therefore they don't have scarlet fever. Children with measles have really red eyes and they're incredibly unwell. And people aren't really used to seeing it here because it's so rare. They're much more unwell than you would expect. And then the last thing I think we need to mention, because I always get this, I get this quite a lot, is EBV. So the teenagers who turned up with sore throat and a rash.
So I think this is the other thing I was thinking of when I mentioned antibiotic rashes earlier. So EBV in its own right actually gives about 10% of kids a rash, which I think people don't realize. And they'll often have a fever, they're quite fatigued, and they might often have lymph node involvement. So they'll have palpable lymph nodes somewhere. And the rash is much more macular papular and not palpable in the same way that the scarlet fever rash is. And we are likely to see the kind of post-antibiotic EBV amoxil related rash. And so it's worth that timing of rash onset is also going to be really important in this cohort. And EBV is a common virus.
So Epstein-Barr virus, glandular fever, I always think, again, it's going back to the history. This is often in older children. They have this slightly different history. And the other thing is that I get this question all the time in the emergency department. People say, oh, maybe I shouldn't give amoxil because I don't know if this is EBV. But the incidence of amoxicillin-driven rash in EBV is actually relatively small. And if you take a good history, and if they're much older and you think it's EBV, fine. But in young children, EBV causes a very minor kind of viral illness. So it is all about going back to the history again.
I think when we're talking about rashes, and Liz, you mentioned this, it's really important to recognize that a lot of the textbook descriptions describe how rashes look on white or Caucasian skin. And I think this would be a really useful opportunity to signpost some resources for how different rashes might look in people who don't have white skin. And there are various websites such as brownskinmatters.com provide reference photos, as well as the ever trusty DermNet NZ.
You can also use Don't Forget the Bubbles, who've produced a whole section on rashes in non-white skin. The other thing I think we forget about, Liz, is I worked in lots of other countries in the South Pacific, in New Zealand. And actually there, we hardly ever saw sore throats, but we saw lots and lots of skin infections and pustules and impetigo, also caused by group A strep.
Yes. So this goes on to the other end of the spectrum of streptococcal and staphylococcal infections, which cause all sorts of skin infection, cause all sorts of problems. So folliculitis, cellulitis, really worrying things like necrotizing fasciitis that people just need to have at the back of their mind. And actually, this is really important in the context of chickenpox. So we know there's a really strongly recognized association between varicella or chickenpox infections and subsequent group A strep infections, both cellulitis and then more worryingly necrotizing fasciitis, which is an extremely painful, just remember, indurated, looks very tender, is very tender, spreads very rapidly, bright red skin infection. And doesn't respond to antibiotics. And this is the reason why when you were a trainee, people got you to draw around red lines. It was literally for necrotizing fasciitis. So just to be aware of that, and that is a type of invasive group A strep that can become very serious very quickly and is a skin emergency, needs plastic surgery and debridement and broad spectrum antibiotics, including potentially ceftriaxone and a toxin killing bacteria antibiotic such as clindamycin or linezolid.
Oh, Liz, so many pearls in one paragraph. So, as always, because we're an infectious disease, we can't actually make a diagnosis unless you do some tests. So it's all about seeing children, thinking about what it could be, and taking some swabs. So what are the samples that people don't do that you want them to do?
That's very good. Well, there was a balance. Not every child who comes in with something needs a swab. If they're being admitted or if you're giving them a treatment for a rash, that's when we want you to do a swab. And we want to have a swab of the site, anything that's wet, basically. We love a wet thing. So you can swab anything that's wet and looks nasty. But also, can you send your MRSA screen at the admission so that if they're not responding after 48 hours, we have a result to know whether to escalate to things like vancomycin? Because it's really annoying when you don't have that. It's good to send groin, anywhere gooey, groin, axilla, neck swabs, and a throat swab will also tell us what kind of commensals are around that we might want to take into consideration for a child who is deteriorating.
And I also ask people to do viral swabs at the same time, because of course, if they're wrong and it's not strep, and in fact you send a rapid viral screen and it comes back as flu A, you've got your answer and you don't need to give antibiotics.
And Liz, the bacterial swabs have another role more than just guiding management for that patient because they have a role in surveillance. Is that right?
Yes, that is such a good point, Christo. So a lot of what we knew for this outbreak going into November, December came from three places. One was scarlet fever notifications, which is GPs and doctors in A&E who tell Public Health England it's a notifiable disease. They have an obligation to tell people if they've made that diagnosis. One is from invasive group A strep notifications. But the third one is surveillance, which is done in a number of laboratories across the country, where they look at the level of positivity of throat swabs for group A strep, for example, but also, as Emma mentioned, positivity in sterile sites. And that will include things like empyema fluid, lumbar puncture fluid, etc., etc.
And that's where, from these notifications and that recent information, that's where we notice this early rise in invasive group A strep. So do you want to tell us a little bit about how it happened and what we should look out for?
Interesting. It actually all happened way longer ago than anyone remembers because, I'm going to give a bit of context. It's going to be a slightly long answer, warning for those with a short attention span. So we had serially high waves of group A strep every spring from 2014 to 2020. And then in 2020, everyone started washing their hands. What were they doing before? And wearing masks, behaving differently. And group A strep really went away in a very dramatic fashion for 2 years. And then it reemerged really late in the season, so early summer last year. And there was an actual alert from UKHSA in July to say that they were worried they were seeing quite high cases of group A strep at that time using the surveillance that we've already mentioned. And that settled down in the summer holidays when everybody washed their hands again, apparently. And then it came back again in the autumn when the children went back to school. And this is unsurprising. Children are the ones who get these infections and they pass it around amongst themselves. And so in the autumn, cases of positive throat swabs and invasive group A strep increased at an unseasonable time of the year, leading to the outbreak that was slightly unexpected in November, December.
That's really interesting. And it makes me feel better because often I say to families when they come with their snotty, miserable children, you don't need antibiotics. Actually, what you need is hand washing, cough hygiene, which means wash your hands before meals, cough into your elbow. If you sneeze into a tissue, throw it away. Do not stick it up your sleeve. Kill it, bin it.
Yes, and it's very interesting. I think we just need to clarify a few things about the actual notifications and what actually has happened in the last few months, because I think the perception, if you were somebody who just read mainstream media, is that the death rate is massive. There's loads of this really severe end of the spectrum invasive group A strep, and it's all a bit of a disaster zone. Actually, although cases have been higher than expected at this time of the year, the proportion of serious cases and tragic deaths and invasive group A strep is completely in proportion. In fact, maybe slightly low compared to the mild and self-limiting illness. So it is just that it's happening at an unusual time of the year rather than it's a disaster zone and that we need to really worry about this particular pathogen. Just the wrong time.
Perfect. And that kind of brings us around to the fact that occasionally group A strep does cause serious invasive infections, but these are very varied. And it kind of brings me around to my general message, which is, do people know how to recognize really sick children? So,
Yeah.
Liz, do you want to talk a bit about the range of invasive group A strep infections that can affect children and why we're really scared of them as a pediatrician?
Yeah. So invasive group A strep is a devastating illness. I'm not going to sugarcoat that, and it is rare, but we do need to know what it means. And what that means is that the streptococcal bacteria has managed to get through our barriers of the skin or the mucosa and into a site where it isn't normally found. And we do see it. I mentioned already chickenpox because you've broken down the skin barrier. It's also can be seen after flu. That's very well recognized when your mucosa is all inflamed and the bugs can get in. And then I think this autumn, we've recognized that other viral infections that cause mucosal damage can allow the bacteria to get in as well. And so we can see meningitis, we can see sepsis, we can see empyema and pleural effusions. We see necrotizing fasciitis in the skin. We also see osteomyelitis and septic arthritis. And all of these are actually surprisingly hard to treat. And so they take quite a long course of antibiotics. But the thing that, as a frontline worker, you need to know is they get very sick very quickly. And that's why it's so devastating. So you might see a child who has a viral infection on one day, and within 24 to 48 hours, they've become very septic very quickly. And that's where the safety netting and telling parents when to come back is the most important part of your job.
Absolutely. I couldn't agree more. And I think that it is hard to understand how quickly that happens. So I think Matt Thomas here in Newcastle did some really nice work that showed that empyemas from group A strep can actually appear within 12 to 24 hours. So really, really quickly. The point about safety netting is my be all and end all, because it's really difficult to think that actually you're seeing a child at one point in time. So you have no idea whether they're going to get better or worse after you leave that room. The only person who can judge that is the parents. And therefore, they need to know what to look out for, when to come and get help, and where to get help. And that doesn't mean that everybody should come to the emergency department. It may mean that you can safely self-care at home. And I'm going to do a huge plug for our Healthier Together website because I think that it has got a really clear red, amber, and green rating scale for parents so that they can look at their children with coughs or colds or fevers and know where and when to get the right treatment.
With regards to treatment of invasive group A strep, what are some of the differences above and beyond the usual care that you provide to a sick child? So fluids, senior review, and so on.
Yeah. So these children are likely to come into A&E being very tachycardic, very hot, tachypneic. So all those things that we hopefully trained you to recognize as red flags. And they need good access. We really want you to get good samples of these children before they get antibiotics. So blood cultures and throat swabs, but absolutely the blood culture. Early antibiotics with broad spectrum. So we use ceftriaxone, but look at your local guidelines. And the thing that's key, if you're particularly worried about group A strep or if there's any profound erythema, redness anywhere, is to add in something that has an antitoxin effect. And the first line is clindamycin. And that's why we add it. It can be stopped if we find another diagnosis, but what it does is it stops the bacteria making more toxin. And it's often the toxin that drives the really devastating rapid process. So the clindamycin is really important here.
Along with antibiotics, is there a role for intravenous immunoglobulin, and what are the limitations around this?
This is a really interesting point. So intravenous immunoglobulin is magic a little bit. And what it does is it mops up that toxin that we were just talking about. And it may have a role, but it should be following discussion with your local tertiary infectious diseases service. It's not going to be appropriate for every child. It is a rare commodity. And it is a big load of fluid. And that may not be helpful if you're somebody who's in shock, where fluid management can be quite tricky. And so these children need first line supportive care. Small fluid boluses. If you're needing more than 20 or 30 ml per kilo, you absolutely need to escalate to your transport services or to your intensive care unit for advice, and consider early inotropes, which they will give you advice about. Those are drugs that help to support the blood pressure. making sure we're monitoring really closely input and output, considering catheterization, and all of those basic tools of looking after a very sick child, which you should be supported with. There are extremely good support systems in our setting, so do reach out and ask for help.
Yeah, I think that the thing to remember for invasive group A strep, it's like any serious disease. If you can recognize it early, then you're more likely to be able to treat it and get a better outcome. Treatment, like the big study from New York, treatment bundles for sepsis include fluids, but just sufficient fluid. So 10 mils per kilo boluses, always reassessing to look if they're overloaded, giving antibiotics early, thinking about whether you need clindamycin, thinking about giving inotropes early, much earlier than we would have before, so after about 40 mils per kilo. And the most important thing of all, which Liz, you said very nicely, is get help. You're never there alone. Who is your local transport service? Is there an anaesthetist in your trust? Do you have intensive care? Don't do this alone. You need help in this situation. We've talked about recognizing very serious invasive group A strep, but I just want to add in, what about contact tracing and treating contacts?
Thanks so much for bringing that up, Emma. This is really crucial. So, group A strep has a very high second attack rate, which means that other people within the household are at risk of becoming unwell. And so, about 1 in 5 of those in the household may develop an infection and actually can be more seriously unwell than the person who presented in the first place, particularly if they're vulnerable. So, vulnerable people are pregnant women or those who have recently given birth, neonates, the elderly, particularly those over 75, and anybody who's immunocompromised. And actually, what you're meant to do is report it to your local health protection team, who can then organise prophylaxis. What I would ask you to do is, if this child or comes into your A&E department at 6 o'clock in the evening, that you just find a way to give antibiotics to a vulnerable person there and then, because actually the health protection team won't get onto the case until the following morning, and these second cases can often occur within 24 hours. So this is where trying to get appropriate prophylactic antibiotics, and it can just be penicillin. There are very clear guidelines on this, can be life-saving.
Yes, absolutely. And we've had cases like that where if a child is brought in and they die, the last thing you need is for their grandparents or their siblings or their pregnant mother to get sick as well. So it's so important and really easy to forget, because actually we're not good at asking who else is living in the family, what are their names, what are their date of births. And I just want a really small point. Liz, what is a household contact?
Household contact is somebody who has lives in the house and spends a large amount of time with the person. So we would say probably more than 8 hours in the last 24 hours would be a significant amount of contact. So around Christmas, it's easy. They spent all of Christmas Day in your house, but they went home to sleep somewhere else. They are still a household contact because they spent the whole of Christmas Day in your house.
Don't worry about the school and the class. That will be somebody else's job, but it is your job to contact public health and for them to trace and sort out that. You're just doing those immediate family contacts.
If you want to notify a case of scarlet fever or invasive group A strep, please contact your local health protection team, whose details you can find on the gov.uk website.
Last of all, so we've been the whole way round from having group A strep as a commensal, sitting on your skin, doing nothing, to causing really invasive disease. But actually, group A strep, it's like a party with a hangover, because you can have post-infectious complications. Just when you think everything has got better, something else happens. So do you want to tell us a bit about the post-infectious complications?
Yes, thank you. So this is what was really fascinating at med school, I thought. So post-streptococcal complications are actually quite rare. We were worried. We are going to do some surveillance to see if we see more of them after this little outbreak. But actually, after the big outbreak in 2017-18, it doesn't appear that there was a big increase in them. So the most common, or the one that you're most likely to see, is post-streptococcal glomerulonephritis. And this is the child who presents 5 to 10 days after a sore throat or an episode of scarlet fever with blood in their urine, in essence. And these children need the usual renal monitoring with blood pressure and urinalysis. After that, we have rheumatic fever, and I'll give a fiver to anyone who can tell me without Googling the Jones criteria. I look them up every time. And this is a combination of carditis and arthritis, so bone and heart involvement. And there are strict criteria that you have to see a problem. You have to identify Strep, so you have a positive throat swab or a positive ASOT that's very high, that you have changes on an echo or an ECG, and that you have meet some criteria in terms of the joint involvement. This is really rare in our setting, actually, which is good. It is much more common in low and middle income countries where presumably, and we think that there's a lot more general exposure to streptococcal infections than we see, which is then never treated. But it is an important one to pick up because if not managed well, it can result in damage to the valves of the heart. And then we also see something called Sydenham's chorea. And this is worth looking up on videos. There are lovely videos of the type of unusual movements that are chorea, which is often writhing or gripping and grasping. And again, this needs management between rheumatology, neurology, and infectious diseases. And the reason all of these are important is that these children may need to go on to preventative doses of antibiotics for a period afterwards. Discuss with your local ID team.
Fascinating, Liz. Yeah, it's really interesting that it's so rare and that there wasn't a huge spike of the last lot of complications. One of the things I wanted to say was if you give antibiotics, although that reduces the incidence of rheumatic fever, there is no evidence that it reduces the other complications. You can still get those. So I think that's another reason not to give loads and loads of antibiotics. As you say, all these things are rare. I do see a bit of post-streptococcal or post-infectious arthritis, juvenile arthritis. And these are children who have red swollen joints for more than 6 weeks and need high dose brufen. And then when you stop it, the symptoms come back. And I do send those to the rheumatologist, and that's a little bit more common, but they don't have the full rheumatic fever criteria. So I see that a little bit more often.
Little interesting point about the arthritis and arthralgia with streptococcal infection. It is very sensitive to aspirin and non-steroidals, where the arthritis due to juvenile idiopathic arthritis tends not to respond so nicely. So it's always worth a trial of good dosing of ibuprofen or even naproxen for these children as part of that, trying to understand what's going on.
Liz, you mentioned measuring anti-streptolysin O titer or ASOT. What are some of the limitations with this? Because I think it's something that if you try and read about, there's often a lot of conflicts about how useful it is in day-to-day clinical practice.
Yes, I should never have mentioned it. So anti-streptolysin O titer is an antibody response to having streptococcal infections. And we told you this is really common. And actually, if you took a cohort of children, a huge number of them would have a positive ASOT, and usually in the range of between, so it comes in ranges depending on how much of it is around and how much you have to dilute the sample in order to find it. And so we would tend to see children who have a range of 200 to 800 relatively commonly. If you've had a very severe or very recent infection, your titer is more likely to be above 1200 or even up to 3600. So that's the kind of range where we would consider that to be significant. But I agree, as a kind of screening tool, it's not very useful. You have to take it in the context of the child and the history of they presented with and what your question is. So you can't just do it. You have to know what you're asking about.
I hate the ASOT because it's always sent and by people who don't have to look at the result.
I was going to say that we just audited our ASOT. I just got all of the ASOTs that have been sent in the trust and in under 21-year-olds, and the positivity rate is ridiculous. It's all like 200 to 400. It's the most useless test on the planet. Anyway.
Liz, it's been so nice talking to you. Really enjoyable and so informative. I've really, really brought things into focus in a very succinct and efficient way. Have you got, at the end of all these podcasts, we give you the chance to give us your 3 top tips It's like a desert island where you can only have 3 messages.
So remember, you should behave the way you behaved at any other time when you saw a child in A&E, and your behaviour should not change just because of differences in reporting of a bug in the media, whether that is group A strep or something else. The child needs an assessment to see if they're septic. They need reassurance if they don't need antibiotics, and they need good safety netting on their way home.
Christo, do you want some top tips as well? You're looking very cheerful this morning.
I think my take-home messages from discussing group A strep with Liz are that there is a difference between being colonized with group A strep and having group A strep infection, and that working this out based on swabs alone can sometimes be difficult, and so you have to take the child in front of you and rely on the messages you get from parents or carers about how worried they are about their child. When it comes to treatment, ignoring patients with invasive group A strep who need rapid, prompt, broad-spectrum antibiotics. Treatment for most of the manifestations of group A strep might reduce symptom duration by a couple of days, but comes with the potential risk of side effects. And so you have to make a balanced decision for each patient in front of you.
Perfect. Now I'm going to give myself 3 top tips because, I think that I like the last word. First of all, don't give antibiotics unless you really need to. If you need to give antibiotics, I want to give a huge plug to the UK Paediatric Antimicrobial Stewardship Group, who have really good guidelines for prescribing antibiotics in different situations. If you were going to give antibiotics, can this be done by swallowing pills? Please look at our pill swallowing podcasts and Kids Med information. Think if the child is over 5, why haven't they learned this skill for life? And last of all, this is for everybody, always safety netting. Safety netting is vital. You only see a child at one point in time. How are the parents going to recognize if they get worse, and what do they do? I give a huge plug to the Healthier Together national network. Enormous large work by Sanjay Patel in Wessex, but it's all the way across the country. South Yorkshire has a brilliant site. North East, North Cumberland also. So do you have a local Healthier Together website where you can directly text the parent the right information at the right time? So it just leaves me to say huge thanks, Liz. Absolute pleasure. We might even ask you again.
Thanks so much. I've really enjoyed myself. Thank you.
This podcast is a collaboration between Medisense Medical Education and the Royal College of Paediatrics and Child Health. You can find more creative learning resources on www.medisense.org.uk, and of course a wealth of information on the important work of RCPCH on rcpch.ac.uk or #ChoosePaediatrics.
The views, thoughts and opinions expressed in this podcast relate solely to the speaker and not necessarily to their employer, organisation, the Royal College of Paediatrics and Child Health, or any other group or individual.